Great. I love that. I love that story and how it, and Amber, thank you for sharing your story. I think it's incredible to see the wonderful things our system can do, right? We know that our system can and does do incredible things and lifts people up and saves lives. Our conversation today is going to be a little bit spicy about holding that in our minds and our hearts, what the system can do. What is getting in the way of it doing that for everybody, right? I think Susan said, care for everybody, anywhere, at any time, right? But we're not quite meeting that aspiration every day. So I'm excited. I'm Kana Enomoto. I'm from McKinsey Health Institute. I've got 3 fantastic panelists. I'll ask each of them when they speak to introduce themselves for the first time. But we're going to start. It says alignment for impact. I think in order to understand how to align for impact, we need to have a shared understanding of what our goal is. And so I'd like each of the panelists to start with, what does, I think the question that Daryl asked, right? What does a well-coordinated, well-functioning system look like to you? So that puts into context a little bit of what we're going to talk about this morning. Marko, do you want to start us off?
Sure. Can you hear me okay? Marko Mijic, it's nice to see so many familiar faces. I'm with Kaiser Permanente, Vice President for Community Health, but spent the last decade working for the state of California and the last 6 years working under Secretary Galley. So it's like a homecoming, and Jacey's here too in terms of being here. I think for me, as I think about what does a system look like, I try to put myself in the center of that conversation because I'm a person with lived experience. I had pretty significant adverse childhood experiences. I'm a refugee who came to this country at the age of 11. My parents and I went into hiding for a period of time. And I didn't realize until later on in life that many of those experiences really manifested as anxiety and depression. And it wasn't until the last couple of years that really that has come to the forefront. And so when I think about what does a system really need to look like, I try to think about the various bifurcations, the bureaucracy, the complexity of how you navigate the system, and my own experience in navigating the system. I also think about it as a parent of a 3-year-old and an 8-year-old. And I think that, to me, it's been very akin to the healthcare experience, which is we are very good at treating people when they get really sick. You have a heart attack, you have a stroke, we will deliver best-in-class care. But what we do a really poor job of is really talking about and thinking about and delivering on early intervention and prevention. And so as a father, to me, it's about how do I equip my kiddos to be able to kind of navigate and have open conversations about their mental health and be able to drive that early intervention and prevention. My 3-year-old, I was really frustrated with my computer the other day. And you could sense that I was frustrated because I was late to a really important meeting. And she said, "Daddy, Miss Joanna taught us to breathe, so breathe with me." And I think it's that early intervention, that prevention piece that I think is really important. So to me, as I think about the system, I think about it, the families that are experiencing it, the individuals that are experiencing it, and how do we create a system that really, it doesn't matter who your payer is, it doesn't really matter kind of what your background is, that you're really having an experience that meets you where you are and delivers on the care that you need in that moment in time.
Good morning, everyone. I'm Jacey Cooper, and I come to this conversation with 20 years in the Medicaid or Medi-Cal space. The first decade, I say, on the delivery system, both in the county and public hospital side, and the second decade in state and federal government. When I think about behavioral health, I think about the fact that currently in California, it's working as it was designed to work. But is that design really where we are and what we expect of the system today? And I think most of us would say no. The fragmentation and some of the complexity has really driven a very challenging system, as Marko just described. We built a system in California around stability. And that looks different in different ways, whether that's how you're talking about how we finance it, or the various systems that we have tapped for different pieces. But that's all been at the cost of the ultimate impacts for people. So we have normalized the facts that we are okay with the complexity at the cost of the outcomes and the impact on people. And so when I think about how we can envision a system where we all want to be, I think that, care coordination doesn't fail because it's people don't care. Because I know, and I've worked in the system for a long time across counties, across managed care plans, across providers, across criminal justice providers, homeless and housing providers, community-based organizations, everybody cares. So this is not a function of care, will, hope, all the things we talked about. This is a complex problem around the systems that we have created, the complexity that we have created in a system. And when that fails, it's really hard to do those things. So my top priority for how do we get to a system is really thinking about financing and accountability. And there's nothing that breaks that down faster when money and responsibility are pointing in different directions. And so really thinking about how do we think about our systems, how do we think about that integration, and have real conversations to realize the system that I think every single person in this room wants, for it to be for people at the end of the day so that they can get access to high quality early interventions when possible, and when not, quick interventions for people in crisis.
Well said, JC. Hi, folks. My name is Al Guida. I'm with something called Guide Consulting Services. We recently moved to a larger outfit called Hellsperian. I am a contract lobbyist in Washington, D.C., which means I'm the lowest form of human life. I've been doing that. I've been lobbying on mental health and addiction treatment services in Washington, D.C. for 30 years, so please forgive me. Let's see here. What does a well-functioning mental health and addiction treatment system look like? So the through line, ladies and gentlemen, when you're lobbying for mental health and addiction treatment services in Washington, D.C. is we want what they have. They being our primary care and medical surgical brothers and sisters, because they have all the resources and we ain't got nothing. So I come at this with a very large chip on my shoulder. And because I'm a street kid from New Haven, I grew up with a man with schizophrenia. So that's my father. And so I've always had a chip on my shoulder in conjunction with the advocacy I do in this space. So I don't want to be abstract about this. What a well-functioning mental health system looks like is the following. At the moment of crisis, when you are in a crisis, the person that arrives at your door when a family member reaches out for help is not a police officer who is armed. It is someone, hopefully, with a mobile crisis team that will de-escalate the situation and reduce the odds that your family member will be shot because they are engaged in what we call the positive symptoms of a severe mental illness that looks like threatening behavior to that police officer. That's what a well-functioning mental health and addiction treatment system looks like in my eyes.
Thank you. Thanks to all three of you. I think this is, as you can see, we're getting off to a good start. I want to unpack a little bit more, JC, what you started with, right? Like you've said that the same mechanisms that have ensured stability are now constraining our system's ability to advance equity, achieve integration, and really deliver on accountability. Can you say a little bit more? And I'm going to ask each of you to speak to what's like some self-inflicted injuries that we've seen where, the state has done something with very good intentions and sometimes with really positive outcomes, but then that has later come home to roost for us.
Yeah, so I mean, if you look at it, I'll look at it from the lens of policy delivery and then payment. So policy-wise, we want coordinated care across county behavioral health, across managed care plans, criminal justice system, housing and homelessness. We want coordinated care. We want integrated systems We want to meet people where they are. We want no wrong door. These are policy concepts that we want. And then we expect the delivery system to work across all of those areas. For county to be working with managed care plans, to be working across a multitude of various systems. And then we finance them all very separately. And they all have different responsibilities, different accountability. In California, we hold accountable who pays. That's kind of how broadly things work. And so when you start thinking about that payment, in the behavioral health side, we have realignment. We have now MHSA, BHSA, and a plethora of federal block grants that come down and fund that system. And over time, we have really focused on the stability of those dollars. It's all about securing dollars, predictability of those dollars. That has been a huge priority, a kind of principle in the behavioral health world of protecting who's providing the services and protecting the actual dollars that are there. And that is important. You need to protect dollars. It's great that there has been a $15 billion investment in behavioral health. Those are really important things and don't want to take away of those really important things. But we also created a system where behavioral health is unique. We have separated the responsibility across the continuum. It's not just like carving out dental, where you can go get all your dental services from a carved out entity. We have carved out pieces of the pie. Emergency room and involuntary detox is managed care, and they cover the non-specialty mental health and the interventions prior to pieces. The counties cover specialty mental health, SUD, and different pieces. So across the entire continuum for a human who's navigating that, and a family that's navigating that from childhood to adulthood, from early intervention to crisis, changes along that entire trajectory. So the impact that the carve-out has had in the ability for us to see our system change is very, very real. Because then accountability lies with different people. And so when it comes to payment, some people are going to protect their budget. All the decisions around protecting the dollar, depending the who. They're not always willing to take the risk when it's not their responsibility. But the system that we've created can only work, can only achieve the outcomes that all of us in this room want if everything works perfectly. And by that, I mean the data systems are flowing perfectly. Everybody understands their role across those various pieces. Every handoff between those systems that happens often happens seamlessly. We essentially have a very comprehensive system in California. We have all the pieces of the puzzle. We are very, very lucky in the state of California to have the benefits and the options that we have. However, we have made that very complicated to navigate. And so I say that to say, we have to look at all of those things. You have to align the policy with the responsibility, with the financing. And there has to be seamlessness around that. And that does take larger fundamental changes. I acknowledge that. But until we're really willing to have those conversations, we are going to keep putting a lot of pressure on our workforce, on our providers, on our systems. We are going to fund way more than we should unless we really align across policy, responsibility, and financing to really drive towards those outcomes that we want.
Thank you.
Yeah, I mean, I think just piggybacking a little bit off of Jacey's comments, I think the fragmentation of the system is really problematic. The fact that, mild to moderate is handled in one space and severe mental illness is another. If I'm putting myself in a position of an individual, I don't that label doesn't mean much to me, and yet I'm falling right through the cracks, right? Because we're not holding us collectively as a system accountable. And so I think that there's just a lot of opportunity on the fragmentation. What I will also just say in stepping back is the system is fragmented and we have different parts of it. And then over the last couple of years, we've added an exorbitant number of new efforts. And to the earlier panel, Senator Eggman and others talking about kind of implementation. Yes, and what we've not done is really focused on culture change and change management to be able to help people understand how these things puzzle together. Because some of us in the room understand the implications of Prop 1 with BH Connect, with Cal AIM, to the average person on the ground who's delivering these things, this means nothing. And so one of the things that I think we need to really think about as we move into the next couple of months and years is how do we puzzle these pieces together so people understand what that journey looks like so they can implement it on the ground. And many of us have been in the system for decades, and we've been oriented in these buckets. And what we need to do is really step back and say, how do we change manage? How do we create the culture change amongst the different organizations to really drive this conversation? You can have the best policy ideas, you could have the best financing mechanisms behind them, but if you do not have the right implementation strategies, and if you're not driving culture change and change management across the system, you will fail. And so my worry as we're in this pivotal moment is we've put all the pieces of the puzzle on the table and we're beginning to pull it together. I think if we don't strategically think about how we connect those dots for people on the ground, we will lose this moment in time, and shame on us if we actually don't get that pulled together.
Well said, Marko. So, Kana, I have to engage in a disclosure before I answer your question. So one of my clients is the National Council for Mental Well-Being. It is the nation's trade association representing 3,200 community mental health centers and community-based providers serving 10 million individuals with mental health and addiction treatment services in the United States. 50% of that patient population are Medicaid-eligible individuals. So how has California shot itself in the foot? So it has done so by not drawing down the certified community behavioral health clinic Medicaid option. Now, and that's a personal frustration for me. So now that I'm here in Sacramento, I think I understand why. You have 15 different behavioral health, Medicaid initiatives that somehow touch on Medi-Cal financing and a $15 billion budget. So now I understand why you made this unfortunate decision. But I have to say two things. Number one is the Certified Community Behavioral Health Clinic Medicaid option that 20 other states have drawn down is a national model to integrate care for persons with mental illness. Because, among other things, at intake, at psychiatric intake, the individual receives a full and complete psychiatric and medical surgical evaluation. And then from that evaluation, it is required that that individual has both a medical surgical and a psychiatric workup and then care coordination from that intake. So it is a unique national model. It is held up as a national model for coordinating care and integrating care for that individual. Issue number one. Issue number two is it is led by a California member, Representative Doris Matsui. In fact, I think we are sitting in her congressional district, if I'm not mistaken. So I think she would want me to tell you that you are shooting yourself in the foot by not drawing down that Medicaid option. Issue number three. HR 1 is going to be, today, ladies and gentlemen, is February 4th. HR 1 is going to be implemented early next year. That's when the work requirements go into effect here in California and nationwide. That's when you are going to start losing Medicaid coverage. The Congressional Budget Office estimates that 5 million Americans will lose Medicaid coverage as a result of the implementation alone of the Medicaid work requirements. California is the state that will lose the largest number of Medicaid eligible individuals, okay? So in addition, California has drawn down a Medicaid option for mobile crisis. That will expire next year, okay? So the time for leaving dollars on the table, Medicaid dollars on the table, is over. Okay? So it's about time that the states start thinking about drawing down Medicaid dollars that are available to finance additional. I'm sorry. I know you have a lot of Medicaid. I know you have a lot of stuff that you've already started, and I'm the person to tell you, yeah, there's another Medicaid initiative in the behavioral health space that you have to start. It's called Certified Community Behavioral Health Clinics. There's an 85% match that's available to you tomorrow to finance this additional option. It's about time you do it. Yes, I have some personal frustration that you haven't done it to date. You know what? Representative Matsui, I suspect, is also frustrated that you haven't done it to date. Thank you.
All right. Jacey, we'd love to have your response or just your thoughts on that, given where you've sat and the decisions that you've had to make.
If decisions were that easy in California, I think it actually goes to what I was saying before. I mean, the way we finance and the way decisions get made are very complicated, right? So the mobile crisis, as an example, or just all decisions, when it comes to behavioral health, because of key provisions that exist in California, it comes down to, are we putting in additional dollars or are we going to make it voluntary? That's how decisions are made for benefits that get implemented here. And those are hard decisions that get made all the time. Once it's voluntary, it's at the county has to make a choice. They have to make a choice. Am I going to lead for innovation and evidence-based and draw and take this on and put in the general or the dollars that they have at the county? Or am I gonna leave that on the table? Which is why you have 56 different behavioral health programs in the state of California. And we are going through a massive transformation of even making sure we're maximizing federal funds, making sure we're drawing down various pieces across these various areas. But the fundamental foundation in which we finance and make policy decisions in California does not seem intuitive to the outside world, because it's not always intuitive for the outcomes that we all want and what we think should happen. And so it's always a really complicated, when I go out and I'm talking to people nationally about the way we do things, it's really hard to explain to people in the rest of healthcare, because it's not intuitive when your policy, your responsibility, and your financing needs to align. And I'm not talking about revenue. Revenue is different. The way we pull down revenue for behavioral health, that's realignment through vehicle licenses, tax, et cetera. That's revenue. We choose how we want to finance something. There's two fundamentally different things. And they've always been put together as if they're one and inevitable. But we have to start thinking about those things differently. Gotcha.
JC, here's what I'd say now. Let's hope, and apparently Mr. Zuckerberg and Mr. Brin have a different view of the referendum that's going to tax the rich and then somehow bail the state of California out. But if that doesn't pass, or there's some other difficulty, then the days of surpluses are over. So then you're going to be confronted with this situation, particularly where Medi-Cal is going to take a big hit. And because the Republicans in Congress and every Republican member of the California congressional delegation voted for H.R. 1. It is what it is. That's why it passed. So as a result, you're going to, so I'm sorry. I mean, I want to give hope. Okay, I want to be the ray of sunshine, and we'll try to be the ray of sunshine at the end. In the meantime, I'm the cloud over this particular gathering here. All right. So you're going to be in a difficult situation. Okay. So again, the days of leaving behavioral health 85% match specific dollars on the table are over. So to the extent that you have to have a rational conversation with specific county government to say, holy cow, we're in some trouble here, and we have to start drawing down some of these initiatives that other states have drawn down to be able to improve their behavioral health care system, because we're going to need these resources. Now, by the way, certified community behavioral health clinics are required to have 24/7 emergency, including mobile crisis and crisis receiving and stabilization. That's a required service that will make up, in case you lose your mobile crisis option, those are rational policies. And maybe it's time to have a rational policy with some of your county government to think about how to make up for some of this lost revenue that might occur if HR 1 is implemented in a way that would negatively impact the behavioral health system in the state. It just seems like a rational conversation to have.
Yeah. Thank you. And Jacey, I hear your point about sometimes things don't look rational because of the complicated way and in the nuanced way in which the California state system is built. Marko, you have once said or wrote that, you know, the behavioral health system in California, which is a fragmented landscape that often feels too opaque, even to those working inside of it. Help us, you know, Kaiser is an employer of one of the largest behavioral health provider populations in the state. Tell me a little bit about workforce and how you're dealing with those challenges, what you think can be done to transform where we are today, where we need to head.
Yeah, I mean, I think to my earlier point, I think we have all these, and especially in California, I mean, we Kaiser Permanente are in 9 different markets, but in California specifically, we have all these puzzle pieces that we've put together, and Dr. Galley used to allude to these puzzle pieces, right? But I think what we've done a poor job is really helping people understand how these things ultimately come together. And I think part of our work is really trying to figure out how we leverage the various pieces of that big puzzle board to be able to say, like, this is how we help enable people across the continuum and across levels. I think the other thing I will just say is that we're spending a lot of time from a community health perspective really thinking about the licensure continuum. I call it the licensure continuum because it starts at getting kids exposed through their lived experience and having them understand that, yeah, they can be peer support specialists or providers on one end, and tomorrow they can go and get their MSW. One thing that is really interesting is that 57% of individuals who finish their MSW do not get to licensure. And I call that the last mile. And people are falling through the cracks because they either can't navigate the bureaucracy of licensure, they can't finalize some of their training, or they don't have the resources to be able to complete licensure. And so I think for us, really, it's about a few different things. One is helping our providers and our systems understand how we leverage all these moving pieces within the ecosystem of California to be able to say this, we're not doing this in isolation, right? There are things that are ultimately interconnected, and we've got to figure out how we connect those dots much more strategically. And to my point earlier, it's about change management, it's about culture change to be able to help people understand what this means on the ground. And I think we've got to really think about how we engage individuals across the continuum to create that ladder of opportunity, to create those pipelines for people to get into the profession. So today you can be a peer support provider. Tomorrow you can be an MSW clinical or a clinical psychologist. The pipeline is really broad, and we've got to really focus on the last mile, which is there are plenty of people who are completing their MSW training. They're not getting the licensure. And how do we get them to that licensure component? What can we do as a health system to be able to support them either to find the appropriate training and or make sure that they've got the resources to complete that is going to be really important moving forward.
The thing I would add on to that from the workforce, and once they're in, we also in our system we have significant burnout that happens in workforce. So say they get through all of the challenges that Marko just highlighted, which are very real. But the complexity of our system, it's very comprehensive, but it's also very complex. And navigating that has real burnout for providers at every level. And until we reduce some of that administrative burden, because a lot of it is administrative burden that exists across these systems, we will keep having people leave the system, even once they have the most dedicated heart that they want to do, coming in and spending a significant portion of their time on administrative functions versus the care for an individual. Eventually they'll burn out. And there's nothing more detrimental than losing a dedicated provider from the system because of burnout or because of the system we've created, because when we talk about how important coordination is across all of these systems, essentially it doesn't work without integration and coordination. That is built on relationships and trust. Relationships and trust between that provider and the patient or client in front of them, relationships across those various systems that they've created, whether it's the plan, the criminal justice, the housing and homelessness. And when you lose someone who has built those relationships, you are essentially breaking down the system and the coordination that exists. So you have to maintain those providers because we rely on them in order to make the system that we have created work. And those relationships, that's the turnover. It's not just turnover of people, it's the turnover of relationships and the knowledge of how to navigate that system well that we are losing when we lose to burnout.
So just to pick up on something that JC just said, so as the person that helped introduce the Behavioral Health Paperwork Reduction Act in the Congress, so the average primary care provider, a federally qualified health center, I think has 15 different funding sources. The community behavioral health provider has an average of 52 separate funding sources. So that's different financing, different financing sources, different patient definitions, different billing systems, different billing codes. So just running around, just the enormous paperwork burden that the workforce has to keep up with contributes to burnout. Now, there's a couple of other things here. So the introduction of AI scribes has apparently assisted with the mental health of the mental health workforce, and we have a couple of relationships with like 4 or 5 AI companies and the introduction of AI scribes into the community-based mental health system has apparently improved the quality of life for the existing mental health workforce. And then finally, behavioral health workforce. And then finally, HR 5733, it's another piece of legislation that we've introduced, the Community Mental Health Wellness Training Act. So it's a piece of legislation that tries to create, at least at the national level, apparently you have a model here in California. These are not peer support professionals. It is a community mental wellness worker. So these are folks from the community, often have a high school degree. They do not have a prior history of mental illness. They do not have a lived experience. And the idea is that the provider will recruit from the community, and then there'll be a clinical social worker on staff, and then coordinate with this individual using technology as basically a tertiary prevention worker. The idea is to create connections in the community, using individuals in the community with the goal of early intervention and then caseload management. So it's something that we're pursuing with Representative Espelot from Manhattan and Representative Lawler from New York. At least to me, anyway, it's a kind of a new behavioral health profession to try to ease the burden of the existing behavioral health workforce.
Yeah. Yeah, I think California sort of led the way with the behavioral health coaches, and I think. And just to clarify, it's not people who have never had a diagnosis, but they're not required to have lived experience in order to become a lay provider. But delivering evidence-based interventions is pretty robustly demonstrated to be effective. So excited to see innovation like that taking hold in California first. That's a brag and steal item. I think it does touch on, Al, you brought on innovation, technology. There's a tension between we want to innovate, we are extremely innovative in California, and like don't add anything else to the list of things we need to do. Right? Can you speak to that tension a little bit where policy, technology, and then sort of the provider's real lived experience kind of come into conflict when it comes to innovation?
Yeah, I mean, I think that this is real, and I think that part of the challenge really is that we are keeping the status quo, yet the world around us is changing pretty dramatically. And so I think, I know that, we're all collectively exhausted from the COVID pandemic plus all the changes, the rapid changes that are happening. But at the same time, I think it is about leveraging this moment in time to really think about how we think about the delivery of care differently. And I've been contemplating this quite a bit recently in the context of productivity growth. And I don't mean productivity growth from a perspective of like, how do you do more with what you have? Or like, how do you pump out more from an individual? That's not what I mean here. But when I look at like the manufacturing industry, when you look at the banking industry, when you look at the logistics industry, these are all parts of the economy that have looked at productivity growth and really have they've increased their productivity growth chart, right? In healthcare and even in behavioral health, one could argue that productivity growth really has been stagnant or declining. And so I think part of this is like, how do we continue to push the envelope around innovative new ways in which we deliver care and or blend and braid these resources in a different way to drive that productivity growth up? Again, it's not about any one individual provider or group of providers that are not doing enough. It's more about the system as a whole and how we drive that system in a different way. The last thing I will just say is that I think part of this is also just stepping back to my earlier comment, and I know I'm like beating the horse on culture change and change management. Part of this is knowing like what tools you have in the toolbox. And I think some of us we don't fully understand the totality of that toolbox. And so I think being able to say like, how do we take a piece of Proposition 1 and a piece of BH Connect and a piece of CalAIM and bridge these things together at the individual level, at the system level, at the community level is going to be important. And that's part of innovation driving the work forward.
Yeah, I really agree with that. I mean, if you think about all the layers of between the CalAIM, the BH Connect, BHSA, all really good intended programs, all have a lot of hope for what they could achieve. But the rubber will meet the road in regards to implementation, connecting those dots across those things. So it's not treating them as separate siloed programs because they are all hinting at different problems they were trying to fix. But you have to weave that together at the local level. And that's hard when you have workforce challenges and other financial restraints in different pieces. So it's only going to get harder. But where I've seen it work well is when a group of people start with a small piece. You have to break it down into different pieces. And this gets to your point around change management. Everybody has to be at the table. If anything happening in behavioral health just involves just the county, that's a problem, right? There's so many people that have to be at the table. So it's bringing the right people to the table, aligning on what are we trying to achieve together. You all own different parts, whether it's the plan, the county, criminal justice, the housing and homelessness service partners. Everyone owns their part, but aligning on the goal. Financing can flow the way financing will flow, but it's about sitting in a room with people and solving problems together. We don't do that enough in California, probably because everyone's been drinking from a fire hose for so long. It's like, I got a letter from the state. I'm going to react to the letter. I got to comply. I need to implement this thing. I'm checking boxes. Have I done all the things? Am I going to pass an audit? Instead of sitting in a room and thinking through soup to nuts, beginning to end, how is this going to work? That policy doesn't make sense. We need to maybe advocate or do different pieces. There has to be bi-directional conversations. I used to say oftentimes, just because it's in a contract, just because it's in a managed care plan contract or a county behavioral health contract does not make it so. That is the beginning of the conversation. Those things were the beginning of the conversation. The rest has to happen locally. We have to give enough flexibility to make things come to fruition, but enough accountability to make sure we're actually moving towards where we want to go. It's this balance that has to happen for all these very well-intended, great programs to come to fruition, but it starts locally with people having conversations with the right people at the table, willing to have that conversation. It takes the state being willing to have a bi-directional conversation with, okay, sounded good on paper. How's that working on the ground level? Not so good? All right, let's talk about that. It takes accountability at every single level to see it change.
I think just to piggyback off your comment, it's almost like in the child welfare space, we have this notion of child and family teams. Like the idea is that the child is at the center of the table, and all of the different parts of the system are coming together to serve that child in a different. I think that analogy is beautiful in the context of some of this work. Part of this is like we all need to come together around the table and say, here are the resources that we've got, and it's less about who the payer of last resort is. It's more about like what gaps are we trying to fill and trying to sort out to say like this is the gap that we're going to fill to be able to make that need. I think that CFT type of mentality is what we really have to draw on to bring these relationships forward. And, you know, we're trying to think about this even in the context of schools with the Children and Youth Behavioral Health Initiative and the fact that we have the ability to now have schools continue and other players bill health plans for services. Schools don't have, I mean, you talk to school districts and schools, they have no idea the processes of health plans. And so just bringing people together around a table and saying like, this is what we do and this is how we do it to help them understand the various systems is going to be really important moving forward.
Wholeheartedly agree. And I just one small plug when we're talking about systems and folks to have around the table, I do think it's also purchasers and commercial employers, right? Because there are, you know, we have systems of care for children and family. We have recovery-oriented systems of care. We have coordinated specialty care. They wrap around people. It's often just in the Medicaid population, right? Or state-funded programs. And so then those programs end up absorbing the people with commercial insurance who don't have access to those evidence-based practices through their commercial health plan. So I think that's, you know, an opportunity there for another set of stakeholders to keep at the table. So I would love to, we're going to end on a good note. This is our brag and steal moment. Some of us aren't, I don't live in California anymore, although I am a Californian. What is something that California is really getting right that those of us who aren't from California, people who aren't in this room, should be looking to California and looking for the opportunities to learn, steal, borrow?
Got it.
They had this question in advance, so like it shouldn't take this long.
All right, now let me start. Now, I did express my frustration with California with respect to my own personal issues relative to my lobby practice. California, so look, you've had a 25% reduction in opioid overdoses in the state in the last 2 years. Significant reductions in homelessness in both Los Angeles and San Francisco. And that is because the governor's made it a priority and because you have reformed how the mental health system interacts with your housing authorities to provide transitional and permanent housing for individuals who are homeless in the state. Last thing on this, one of my clients is the National Association of State Mental Health Program Directors. We help to represent the state mental health agencies on Capitol Hill. Now, typically, when you hear, and when a governor hears from their state behavioral health agency, it's bad news. There's been a death in the state, in the state hospital, and that's when you hear from the state behavioral health director. In this case, and Senator Steinberg indicated that most governors do not want to lead with mental health and addiction treatment. In this case, you had a governor that is just about to step down that made this a priority. I mean, I want to tell you something, $15 billion is one hell of a lot of money. And it is very difficult. I want to tell you, as someone whose job it is to generate mental health and addiction treatment financing on Capitol Hill, it is it's a very difficult thing to do. And the idea that this guy put his back behind it and really led with trying to generate resources for this space, holy cow. It's unique.
Yeah, I'll probably piggyback here a little bit. I would say what California should be most proud of, and this isn't just in behavioral health, but in general, is being willing to go first. And there's a lot of responsibility that comes with going first and doing something first and being innovative. It means that you're probably going to do it wrong at the beginning. And we, as a California, are really bad at being okay with that, to be honest with you. We see it as a failure. We point fingers, and there's blame on all sides, whether it's state, county, managed care plans, commercial, whatever it is. But I think we need to develop this concept of, if we want to continue to be the state who puts our neck out, who goes first, who has a governor willing to lean in and fund and do things, we also have to be a state that is willing to learn and grow and collaborate and co-design and do those things together, because that's what you have to do to be successful when you're first. But I think we should always be proud, because we have led in so many ways across so many areas, and it's what we do, it's what we love. It's probably why most of us are in these jobs, because you're always on the edge of how do we continue to fix these problems and do it well. But we also have to have more trust in that across all places to do that well, and be a little bit okay with the fact that we're not always going to get it right on day one. But one thing I've always loved about California is we're always committed to then eventually fixing it and getting it right. Or what we probably need to be better at is when we need to say, all right, we probably need to take that one off the table. We don't take enough off the table. We just keep piling, and eventually the tower tips over. But I would say California should be very proud of being first, being innovators, but the responsibility of that is heavy.
Yeah, I think I agree with what Jacey said. I think what I'm most proud of as I reflect on some of this work is in the ways in which we really continue collectively as a system, not as government entity or not, but how we bring the lived experience of people to the table, and how that is continuing to shape the work that we do. Judge Lucero is here somewhere, but she commissioned a really important piece around the transition of youth from DJJ to the county. And one of the things she commissioned is she asked the team to go into the community to talk to youth to understand what it is that they want. And that report, or that experience, really shaped, I think, her thinking, our thinking about the ways in which we showed up as a system, as a collective. In the early days of the conversation related to BHSA reform or others, the secretary convened many conversations with people with lived experience to understand what were the challenges of their experience. It wasn't perfect. I think we could have done way more, but I'm really proud of how California continues to put people at the center of the conversation. And I think that is going to be important as we continue kind of our collective work to be able to drive it. To Jacey's point around being first means that you've got the target on the back and people are looking for you to fail. And all people are focused on is how you're going to fail and lift up the failure, instead of saying, how do we iterate? And the luxury in government is there's no such thing as failure. Heaven forbid we fail, because the legislature, calls you up and there's a gazillion hearings and the press is all over it. I think we have to be comfortable with the notion that we're going to fail. We're going to fail fast. We're going to fail forward, and we're going to fail often. And so I think part of this is that we've got to be able to move the needle in that, always anchored in kind of this notion of the person. I'm really proud of what we've been able to do in California with that.
Great.
There you go.
Great, thank you. I think just Al once said, some of the things that are happening today are really intended to make us feel helpless, but he's here to tell us that we are not. I want to tell all of you, you are not helpless. I think if there's anything that we could leave you all with, is that we want you to keep trying, keep talking, keep partnering, keep hoping, keep advocating, right, and keep doing what you're doing. So thank you very much.